Hello and welcome. Do you want to successfully complete the D439 OA exam? Then you are in the right place. We built a free question bank for the D439 OA exam. Preparing for an OA is no joke, so our guides and practice questions are completely free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from patient hygiene, skin integrity, clinical nutrition, legal frameworks, patient safety. So, let's get started.
Question 1. A nurse is developing a sleep promotion plan for an older adult admitted to a medical unit who reports trouble falling asleep since admission. Which intervention would best help this patient adjust to the hospital environment while promoting restorative overnight sleep? A. Offer a warm blanket nightly. B. Add an extra sedative dose. C. Replicate the home sleep schedule. D. Keep the room brightly lit. Do you know the answer? Correct answer. C. Replicate the home sleep schedule. Option C works because matching the patient's home sleep routine provides familiarity, cues the body toward its usual rest pattern, and eases hospital-related insomnia more effectively than competing approaches. Option A is incorrect because a warm blanket may add surface comfort but does not address the disrupted routine or circadian timing, which actually drives hospital sleep trouble in older adults. Option B is incorrect because increasing sedation at night contradicts safe sleep promotion practice, raises fall risk in older adults, and masks rather than solves the underlying rhythm disturbance causing the problem. Option D is incorrect because bright lighting at night suppresses melatonin production, keeps the brain alert, and directly blocks the darkness cues needed for normal sleep, onset, and deeper restorative rest. All right. Let's break down the core concept behind this question. Sleep trouble in hospitalized older adults is rarely about the bed itself. It is about the sudden break from the familiar routine the body has used for years to fall asleep. Start with broad health topics, move into lifestyle, and only later move toward the more personal territory. Trust builds gradually. The patient gets comfortable answering smaller questions before the bigger ones come up. Is rarely about the bed itself. It is about the sudden break from the familiar routine the body has used for years to fall asleep. Start with broad health lifestyle, and ADPIE is the nursing process, a different framework entirely. Assessment, diagnosis, planning, implementation, evaluation. It covers overall care planning, not pain specifics. SBAR is a handoff tool. Situation, background, assessment, recommendation. It structures communication to providers, not pain assessment at the bedside. UAAT is the delegation rule, covering tasks that cannot go to a UAP. It governs assignments, not pain. OPQRST is the pain framework. Here's a D4. Question 2. A patient reports worsening insomnia over the past week and wants guidance on lifestyle changes. The nurse reviews the patient's daily habits and looks for modifiable triggers. Which teaching point should the nurse emphasize first to protect normal nighttime sleep? A. Avoid caffeinated beverages during the day. B. Take long naps after lunch, daily. C. Drink hot chocolate just before bed. D. Exercise heavily 1 hour before sleep. Do you know the answer? Correct answer. A. Avoid caffeinated beverages during the day. Option A is correct, because caffeine has a long half-life, and avoiding it during the daytime hours keeps the stimulant from lingering in the body and disrupting the nighttime sleep cycle. Option B is incorrect because long afternoon naps reduce the buildup of sleep pressure, making it much harder to fall asleep at the normal nighttime hour and fragmenting the sleep schedule. Option C is incorrect because hot chocolate contains caffeine and chocolate compounds, both of which the study guide warns to avoid within 4 to 6 hours of bedtime to protect rest. Option D is incorrect because heavy exercise within 4 to 6 hours of bed raises body temperature and alertness, which directly conflicts with the wind-down physiology needed for falling asleep. To really understand why avoiding daytime caffeine sits at the top of the list, you have to look at how caffeine actually behaves inside the body. Caffeine has a long half-life, which means half of what you drank at noon is still active in your system hours later. A coffee at 3 in the afternoon can still be holding your brain awake at 10 at night. That is why daytime caffeine, not just evening caffeine, matters for sleep. Long afternoon naps drain the body's sleep pressure, the drive that builds up the longer you stay awake, and that pressure is what makes falling asleep at night feel natural. Hot chocolate before bed sneaks in caffeine and cocoa stimulants exactly when you need to wind down. Heavy exercise 1 hour before sleep raises core body temperature and heart rate, which pushes the body into alert mode instead of rest mode. The first lever a nurse teaches then is cutting daytime caffeine. Here's a what you D439 OA exam tip for you. When sleep hygiene questions list several habit changes, the caffeine answer almost always wins over the others. Quick recall hook. Caffeine lingers, so cut it early. Question 3. A nurse finds an older patient wandering in the hallway late at night, appearing tired but unable to return to sleep. The patient denies pain and has no clear medical complaint. Which nursing action best supports this patient's return to restful sleep? A. Offer a cup of coffee. B. Turn on overhead room lights. C. Administer an extra sleeping pill. D. Provide a gentle back rub.
Do you know the answer?
Correct answer. D. Provide a gentle back rub. Option D is correct, because a back rub offers calming tactile stimulation, relaxes muscle tension, and matches the study guide recommendation for wandering patients, supporting a smoother return to natural sleep. Option A is incorrect, because coffee contains caffeine, a stimulant that blocks sleep onset, increases nighttime alertness, and worsens the wandering pattern rather than calming the patient back into rest. Option B is incorrect, because turning on bright overhead lights further suppresses melatonin, signals daytime to the brain, and directly opposes the dim environment needed for the body to wind down. Option C is incorrect, because adding sedatives without a clear order raises fall risk, may cause confusion in older adults, and conflicts with the guideline against increasing nighttime sedation for wandering. This is a critical concept for the exam, so let's dig into the principle behind this. A wandering older patient at night is a common scene on any medical unit. The instinct is to give something, do something, fix the behavior fast. The study guide pushes back on that instinct. The right move is the gentle, non-pharmacologic one first, and a back rub is the classic example. A back rub reduces muscle tension, signals safety through touch, and eases the patient back toward drowsiness without adding drug burden. Offering coffee makes the problem worse, because caffeine is a stimulant, and this patient is already failing to sleep. Turning on overhead lights sends a bright daytime signal to the brain, and shuts down melatonin when you need the opposite. Extra sleeping pills without a fresh order are unsafe for older adults, raising fall risk, confusion, and next-day sedation. The calm, tactile, drug-free approach wins IT. Here's a what you give D439 OA exam tip for you. When the patient is wandering and the answer choices mix comfort measures with stimulants or sedatives, comfort wins every time. Quick recall hook. Wandering equals warm touch, not wake-up drinks. Question 4. A home health nurse is counseling a patient who struggles with nighttime sleep and often naps for 2 hours in the afternoon. The patient asks whether short naps could stay in the daily routine. Which response from the nurse best matches safe practice? A. Never take any daytime naps. B. Limit naps to 20 minutes twice. C. Replace night sleep with long naps. D. Nap only after dinner each evening.
What do you think is the answer?
Correct answer. B. Limit naps to 20 minutes twice. Option B matches the study guide because short naps capped at 20 minutes, taken up to twice per day, Refresh the patient without destroying the nighttime sleep drive or routine. Option A is incorrect, because the study guide does not ban all naps outright, and a blanket prohibition ignores that brief daytime rest can be restorative when properly timed and limited. Option C is incorrect, because replacing night sleep with long daytime naps scatters the circadian rhythm, encourages further wandering at night, and does not reliably deliver the deeper stages of sleep. Option D is incorrect, because evening naps push nighttime sleep further back, reduce the body's sleep pressure at bedtime, and are explicitly listed among behaviors that worsen insomnia patterns. Let's explore the theory behind nap timing to see why 20 minutes twice is the right answer. Sleep pressure builds the longer you stay awake. That pressure is what makes bedtime sleep deep and restorative. A long afternoon nap wipes that pressure out, and the body refuses to sleep properly at night. The study guide does not ban naps entirely, because a short rest can refresh without damaging night sleep. The cap is 20 minutes per nap, twice a day at most. Anything longer lets the brain slide into deeper sleep stages, and waking from those stages leaves the patient groggy and the night sleep ruined. Replacing night sleep with long daytime naps scrambles the circadian rhythm and drives the wandering and fragmentation that caused the original problem. Napping after dinner is the worst timing because it pushes the body's sleep window past the normal bedtime. Short and early, that is the rule. Here's a Wagyu D439 OA exam tip for you. On nap questions, scan the options for a specific short duration and a limited count. That combination is almost always correct. Quick recall hook, 20 minutes, twice, that's nice. Question 5. A patient discharged after a hospital stay has developed irregular sleep patterns due to shift work and inconsistent mealtimes. The patient wants a single foundational habit to restore healthy sleep. Which recommendation should the nurse emphasize as the most important starting point for this patient? A. Establish regular bedtime and wake times. B. Sleep with a bright lamp on. C. Read in bed to force drowsiness. D. Drink strong tea before lying down.
Do you know the answer?
Correct answer. A. Establish regular bedtime and wake times. Option A is correct, because fixed sleep and wake times retrain the circadian rhythm, stabilize melatonin release, and provide the single most powerful foundation the study guide highlights for lasting sleep health. Option B is incorrect, because sleeping with a bright lamp on signals daytime to the brain, suppresses melatonin, and directly contradicts the dark bedroom guidance central to basic sleep hygiene education. Option C is incorrect because reading in bed trains the brain to associate the bed with wakeful activity, which the study guide explicitly warns against when building strong sleep associations. Option D is incorrect because strong tea contains caffeine, a stimulant that prolongs sleep latency, reduces deep sleep, and counteracts the relaxation needed during the pre-sleep routine before bed. Picture this situation. A patient returns from a hospital stay, jumps between shift schedules, eats at odd hours, and cannot sleep right anymore. They want one habit to start with. The answer is fixed bedtime and wake times. The circadian rhythm is stubborn. It learns from repetition and resists chaos. When you go to bed and wake up at the same hours every day, melatonin release locks in, body temperature cycles predictably, and sleep quality stabilizes over weeks. Sleeping with a bright lamp on signals daytime and kills melatonin, the opposite of what the patient needs. Reading in bed teaches the brain that bed means awake activity, which weakens the sleep-bed connection the study guide wants to protect. Drinking strong tea before lying down loads caffeine into the body right when it needs to wind down. Fixed times are the single most powerful foundation for sleep repair. Here's a Wagyu D439 OA exam tip for you. When the question asks for the one starting habit, look for the answer that anchors the circadian rhythm. Quick recall hook. Same time to bed, same time up, rhythm locks in. Question 6. A nurse inspects a bedridden patient's sacral area and finds a shallow open sore with partial thickness skin loss involving the epidermis and dermis, along with a visible fluid-filled blister nearby. Based on pressure ulcer staging, which stage best describes this finding? A. Stage 1 pressure ulcer. B. Unstageable pressure ulcer. C. Stage 2 pressure ulcer. D. Deep tissue pressure injury.
Do you know the answer?
Correct answer. C. Stage 2 pressure ulcer. Option C is correct because stage 2 pressure ulcers involve partial thickness loss affecting epidermis and dermis, and the classic teaching marker for stage 2 in this study guide is blister presence. Option A is incorrect because stage 1 pressure ulcers present as red, intact skin with no open area, no blister, and no loss of the surface layers that the question clearly describes. Option B is incorrect because unstageable wounds are covered by eschar or slough that blocks the view of the wound bed, which does not match the visible partial thickness description given. Option D is incorrect because deep tissue pressure injury shows a purple or dead discoloration over bony prominences without the blister or partial thickness, open sore, the question describes here. Here's what the study guide wants you to remember about pressure ulcer stages. Each stage has one signature finding that separates it from the others. Stage 1 is red, intact skin, no break. Stage 2 is partial thickness loss with a blister as the giveaway. Stage 3 goes full thickness into subcutaneous fat. Stage 4 reaches muscle and bone. Unstageable means you cannot see the wound bed because eschar or slough covers it. Deep tissue injury shows purple discoloration with no open wound. This patient has a shallow open sore through the epidermis and dermis, and a fluid-filled blister right next to it. That blister finding is the stage 2 flag the study guide trains you to spot. Stage 1 is out because the skin is already open. Unstageable is out because the wound is visible. Deep tissue injury is out because there is no purple discoloration, and the sore is already open. Blister plus partial thickness loss equals stage 2. Here's a VUG D439 OA exam tip for you. When you see blister in the stem, your answer is stage 2. Quick recall hook. Blister equals 2. Question 7. A nurse completes the Braden scale for a newly admitted older adult and records a total subscale score, suggesting the lowest possible range on that scale. How should the nurse interpret this result and prioritize the patient's skin-related care planning? A. Patient has low risk of ulcers. B. Patient has high risk of ulcers. C. Patient needs no skin interventions. D. Patient has normal skin integrity.
Do you know the answer?
Correct answer. B. Patient has high risk of ulcers. Option B is correct, because on the Braden scale, a study guide teaches that a score of 1 reflects high risk, while a score of 4 reflects low to no risk for skin breakdown. Option A is incorrect, because the lowest Braden score represents the worst skin integrity outlook, not a low-risk finding, and reading it as low risk reverses the meaning of the scale entirely. Option C is incorrect, because a high-risk Braden result mandates active interventions such as repositioning, pressure redistribution, and nutrition support, not the removal of skin protection from the care plan. Option D is incorrect, because a bottom-of-scale score signals vulnerable, at-risk tissue rather than normal integrity, and treating the patient as intact would miss the window for early prevention. Think about the Braden scale like a warning gauge for skin breakdown. The scale uses subscales that score 1 through 4 TAR. A low subscale score means trouble. A high subscale score means the patient is closer to normal. Read it backwards from what feels natural. 1 is the worst, 4 is the best. So when you see the lowest range on the scale, that is high risk for ulcers, not low risk. A high-risk Braden result forces action. The nurse repositions regularly, offloads pressure with cushioning, supports nutrition, and protects the skin with barrier care. Saying the patient has low risk flips the scale backwards. Saying no interventions are needed abandons the very patient the tool just flagged. Saying skin is normal ignores the vulnerable tissue the low score is warning about. The bottom of the scale triggers the full prevention plan. Here's a YGBD 439 OA exam tip for you. On Braden questions, map low number to high risk. Quick recall hook, low score, low safety. Question 8. A nurse assesses a chronic wound on a patient's heel and cannot see the actual depth because the surface is covered by black and brown dead tissue and yellow stringy debris. Which staging decision should the nurse make and document for this wound? A. Stage 3. Pressure ulcer confirmed. B. Stage 1. Pressure ulcer confirmed. C. Deep tissue injury confirmed clinically. D. Unstageable pressure ulcer documented.
What do you think is the answer?
Correct answer. D. Unstageable pressure ulcer documented. Option D is correct, because the study guide identifies eschar as black or brown dead tissue and slough as yellow and stringy, and when these hide the wound bed, the stage is unstageable. Option A is incorrect because stage 3 pressure ulcers require a clear view of full thickness loss into the subcutaneous tissue, which cannot be verified while eschar and slough block the wound bed fully. Option B is incorrect because stage 1 pressure ulcers show only red, intact skin with no open area, which is the opposite of a wound covered by dead tissue and stringy yellow slough. Option C is incorrect because deep tissue pressure injury appears as purple dead discoloration of intact or blistered skin, not as a wound bed hidden beneath eschar and yellow stringy debris. When a wound is covered in dead tissue, staging stops. That is the whole idea behind the unstageable label. The study guide defines eschar as black or brown dead tissue and slough as yellow stringy debris. When either one or both cover the wound bed, the nurse cannot see how deep the injury actually goes. Without depth visibility, you cannot call it stage 3 or stage 4. You cannot even call it stage 1 or stage 2. The tissue is hiding the truth. So the nurse documents the wound as unstageable. Stage 3 needs a clear view of subcutaneous tissue, which this wound does not offer. Stage 1 is intact red skin, which this wound is not. Deep tissue injury appears as purple dead skin over a bony prominence, which also does not match. The presence of eschar and slough together is the staging blocker. Here's a YGD 439 OA exam tip for you. When the stem mentions black or brown tissue plus yellow stringy debris, the answer is unstageable. Quick recall hook. Can't see the bed, can't stage the wound. Question 9. A nurse is caring for a frail older adult with reddened intact skin over both heels and the sacrum, along with tissue that appears purple and feels firm beneath the skin. Which positioning strategy best reduces pressure and supports the tissue in this case? A. 30-degree lateral inclined position. B. Full supine flat position continuously. C. High Fowler's position for hours. D. 90-degree side lying position only.
Can you guess the answer?
Correct answer. A. 30-degree lateral inclined position. Option A is correct, because the study guide lists the 30-degree lateral inclined position as the preferred strategy to release pressure over bony prominences and protect heels, sacrum, and deep tissue. Option B is incorrect, because a flat supine position for long periods concentrates pressure directly over the sacrum and heels, worsening the risk of new injury and extending damage to deep tissue areas. Option C is incorrect, because sustained high Fowler's position increases shear and friction on the sacrum and coccyx, which the study guide links to deep tissue injury and pressure ulcer development over time. Option D is incorrect, because a 90-degree side-lying position places direct weight on the trochanter and ischial tuberosities, creating strong bony prominence pressure that the 30-degree angle is meant to relieve. Positioning matters more than people realize for a patient with reddened skin and purple deep tissue findings. The 30-degree lateral inclined position is the study guide's top pick. It tilts the patient onto the side at a gentle angle, which shifts weight off the heels and sacrum without landing the full body weight on the hip bone or the sitting bone. That tilt spares the bony prominences and eases the pressure that caused the damage. A flat supine position stacks the full body weight right on the sacrum and heels, which is exactly where this patient already has injury. High Fowler's position pushes the body forward and creates shear on the sacrum, a documented driver of deep tissue injury. A 90-degree side-lying position drops the body directly onto the trochanter and ischial tuberosity, creating sharp, bony prominence pressure the 30-degree angle is meant to avoid. 30 degrees is the sweet spot. Here's a BGD D439 OA exam tip for you. On pressure offloading questions, the answer with a specific angle usually wins. Quick recall hook. 30 tilt saves the skin. Question 10 touches. A wound care nurse evaluates a deep sacral wound and documents visible muscle and bone at the wound base, with damage extending through all 4 tissue layers. Which pressure ulcer stage best fits the nurse's objective findings in this documentation? A. Stage 2. Pressure ulcer. B. Stage 1 pressure ulcer. C. Stage 4 pressure ulcer. D. Deep tissue injury only.
Can you guess the answer?
Correct answer. C. Stage 4 pressure ulcer. Option C is correct because stage 4 pressure ulcers penetrate all 4 tissue layers and reach muscle and bone, exactly matching the study guide's depth description and this patient's documented wound base. Option A is incorrect because stage 2 pressure ulcers involve only partial thickness, damage to epidermis and dermis, with a blister as the key marker, not exposure of underlying muscle and bone tissue. Option B is incorrect because stage 1 pressure ulcers show red, intact skin with no open wound, which cannot coexist with a documented wound exposing muscle and bone at its deep base. Option D is incorrect because deep tissue pressure injury appears as purple or dead discoloration over bony prominences and does not by itself equal a stage 4 wound with visible muscle and bone exposure. Stage 4 is the deepest and most serious pressure ulcer on the scale. The study guide draws a clean line. Stage 4 penetrates all 4 tissue layers and exposes muscle and bone at the wound base. Those 2 findings alone settle the staging question. If you see muscle, you see stage 4. If you see bone, you see stage 4. Nothing else on the scale goes that deep. Stage 2 is only partial thickness with a blister. Stage 1 is red intact skin, no open wound at all, and cannot sit alongside a wound bed that reaches bone. Deep tissue injury stays under intact or blistered purple skin and does not, by itself, mean a stage 4 wound. The full 4-layer penetration with visible muscle and bone is the signature that locks the answer to stage 4. Here's a WGO D439 OA exam tip for you. When muscle or bone appears in the stem, jump straight to stage 4. Quick recall hook. Bone in view, stage 4 for you. Question 11. A nurse is about to begin a scheduled bolus central feeding through a patient's nasogastric tube. The head of the bed is currently flat because the patient had been repositioned for a back assessment. What is the most important action before starting the feeding now? A. Flush the tube only. B. Elevate head to 45 degrees. C. Infuse feeding at a faster rate. D. Deflate the tube balloon first.
Do you know the answer?
Correct answer. B. Elevate head to 45 degrees. Option B is correct because the study guide directs nurses to elevate the head of the bed 30 to 45 degrees during feeding to reduce reflux and protect the airway from aspiration. Option A is incorrect because flushing alone does not prevent aspiration while the patient is flat, and the study guide ties feeding safety first to proper head elevation before any tube maintenance steps. Option C is incorrect because a faster infusion rate increases gastric distension and reflux risk, pushing formula upward toward the airway, which is the opposite of safe aspiration prevention practice for patients. Option D is incorrect, because nasogastric feeding tubes used in this context do not rely on a balloon system, and acting on a non-existent balloon step ignores the real aspiration prevention priority entirely. Before any tube feeding starts, head of bed goes up. This is not optional, and it is not a preference. The study guide sets the range at 30 to 45 degrees, and the purpose is airway protection. Formula entering a flat stomach has an easy path back up the esophagus, past the vocal cords, and into the lungs. That is aspiration, and aspiration in a patient receiving tube feedings is a common cause of pneumonia and serious injury. Elevating the head uses gravity to keep formula down where it belongs. Flushing the tube is important, but flushing a flat patient does nothing to stop reflux. Infusing faster overloads the stomach and makes reflux worse, not better. Nasogastric tubes used this way do not have a balloon to deflate, so that step is a distractor. Head up, then feed. Here's a D439 OA exam tip for you. When a feeding question has a flat patient, your first action is always elevate the head. Quick recall hook. Head up, formula down. Question 12. A nurse aspirates gastric contents before a scheduled feeding and withdraws a large residual volume that clearly exceeds the study guide's safety threshold. The patient shows mild abdominal discomfort but no vomiting. Which combination of actions best matches safe nursing practice for this finding? A. Hold the feed and notify the provider. B. Proceed with full feeding as ordered. C. Double the next scheduled feeding volume. D. Flush with juice and start feeding.
Can you guess the answer?
Correct answer. A. Hold the feed and notify the provider. Option A is correct, because the study guide directs nurses to withhold the feed and contact the provider when aspirated residual volume exceeds the safety threshold, protecting the patient from aspiration. Option B is incorrect, because proceeding with a full feed on top of a very high residual stacks formula against a slow emptying stomach, dramatically raising reflux and aspiration risk for the patient. Option C is incorrect, because doubling the next feeding to make up the missed dose worsens gastric overload, violates tube feeding safety principles, and is not supported anywhere in the study guide material. Option D is incorrect because juice is not an approved flushing fluid for enteral tubes, and starting a feed despite the high residual ignores the core reason the volume triggered the initial hold. High residual volume is a red flag the nurse has to respect. When the nurse aspirates gastric contents before a feeding and pulls back more than the safety threshold allows, the stomach is not emptying well. Dumping more formula on top of that pooled volume turns a slow emptying stomach into a reflux factory. Pressure climbs, formula backs up, and aspiration risk rises sharply. The right move is to hold the feed and call the provider. The provider decides the next step, which might involve waiting, rechecking, adjusting the rate, or changing the order. Proceeding with the full feed stacks the problem on itself. Doubling the next feeding to make up lost calories violates the basic safety principle and has no support in the study guide. Flushing with juice and starting the feed introduces an unapproved fluid and ignores the whole reason the hold was triggered. High residual means stop and escalate. Here's a buggy D439 OA exam tip for you. When the residual volume exceeds the threshold, the answer is always hold and notify. Quick recall hook. High residual, high alert. Question 13. A nurse prepares to give a scheduled bolus feeding and gathers supplies at the bedside. The nurse must flush the nasogastric tube before and after delivering the formula to maintain patency and safety. Which action best matches the study guide's flushing recommendation for this routine bolus feed? A. Flush with hot saline each time. B. Flush with a small sip of soda. C. Skip flushing for bolus feedings. D. Flush with water before and after.
What do you think is the answer?
Correct answer. D. Flush with water before and after. Option D is correct, because the study guide directs nurses to flush enteral tubes with water before and after each feeding, which keeps the tube patent and prevents clogging or obstruction. Option A is incorrect, because hot saline is not the study guide flush of choice, may irritate the gastric mucosa, and introduces an unnecessary electrolyte load on top of standard feeding formula. Option B is incorrect because soda is carbonated, acidic, and never listed as a safe flush in the study guide, and using it can damage the tube or upset the patient's stomach. Option C is incorrect because skipping the flush allows formula residue to harden inside the lumen, leading to tube clogging and forcing replacement of the device, which the guideline works to prevent. Flushing the tube is basic, but essential. The study guide keeps it simple. Flush with water before and after each bolus feeding. The purpose is straightforward. Water clears formula residue out of the lumen, keeps the tube patent, and prevents the hard clogs that force early replacement. Hot saline is not the flush of choice. The heat and added electrolytes offer nothing the patient needs and can irritate the gastric lining. Soda is acidic and carbonated, never listed as a safe flush, and can damage the tube itself. Skipping the flush lets formula dry inside the tube, and that dried formula turns into a clog the nurse cannot push through. Water before, water after, every time. Here's a D439 OA exam tip for you. On bolus feeding flush questions, water is always the safe answer. Quick recall hook. Water wins before and after. Question 14. A nurse is midway through a nasogastric feeding when the patient suddenly begins vomiting and coughing violently, showing signs of choking. The feeding pump is still running, and the head of the bed is elevated. What is the nurse's most important immediate action in this situation? A. Continue feeding at a slower rate. B. Lower the head of the bed. C. Stop the feed and suction. D. Remove the tube right away.
Can you guess the answer?
Correct answer. C. Stop the feed and suction. Option C is correct, because the study guide directs nurses to stop the feeding at once, keep the patient upright, suction the airway, and alert the provider when vomiting and choking occur together. Option A is incorrect because continuing formula during vomiting and choking keeps pushing material toward a compromised airway, directly raising aspiration risk instead of relieving the immediate respiratory threat present. Option B is incorrect because lowering the head of the bed allows gastric contents to travel upward more easily toward the trachea, which worsens aspiration rather than protecting the airway during the episode. Option D is incorrect because pulling the tube during active vomiting does not solve the urgent airway issue, and the guideline prioritizes stopping the feed, suctioning, and contacting the provider first always. When vomiting and choking hit together during a tube feeding, the airway is in danger right now. The nurse does not have time to think through options. The study guide spells out the sequence. Stop the feed at once, keep the patient upright, suction the airway, alert the provider. Stopping the feed cuts off the incoming formula. Keeping the patient upright uses gravity to push gastric contents down, not up toward the trachea. Suctioning clears the airway before aspirated material blocks breathing. Calling the provider puts the clinical team on alert. Continuing the feed during active vomiting forces more material toward a compromised airway, which is the exact opposite of safe practice. Lowering the head of the bed lets gastric contents travel even more easily toward the lungs, worsening the aspiration risk. Removing the tube during active vomiting skips the urgent airway steps and wastes precious time. Stop, suction, call. Here's a D439 OA exam tip for you. When the STEM mentions vomiting and choking together, always pick the option that stops the feed and suctions. Quick recall hook. Choke and vomit, stop and suction. Question 15. A nurse is performing routine care on a patient receiving continuous enteral nutrition through a nasogastric tube. The nurse reviews the unit's policy for tubing replacement to prevent infection and maintain system integrity. According to the study guide, how often should the feeding tubing itself be changed? A. Every 12 hours without exception. B. Every 24 hours as scheduled. C. Every 72 hours minimum. D. Only when visibly soiled.
Do you know the answer?
Correct answer. B. Every 24 hours as scheduled. Option B is correct, because the study guide directs nurses to change feeding tubing every 24 hours, which limits bacterial growth inside the set and supports safe delivery of formula to the patient. Option A is incorrect, because a 12-hour interval is more frequent than the guideline requires, increases supply use unnecessarily, and is not the specific time frame taught in the study guide material. Option C is incorrect because waiting 72 hours between tubing changes allows bacterial contamination to accumulate inside the set, exceeding the safety window and raising infection risk for the patient significantly. Option D is incorrect because waiting for visible soiling ignores invisible bacterial growth, which is the main reason tubing has a scheduled replacement interval, rather than a condition-based replacement approach. Tubing changes seem small but matter for infection control. The study guide is specific about timing. Feeding tubing gets changed every 24 hours. Formula sitting inside warm plastic tubing is a perfect environment for bacterial growth. A fresh set every day limits that growth window and keeps the formula reaching the patient clean. 12-hour changes are more frequent than needed, waste supplies, and do not match the guideline. 72 hours is too long. Bacteria have plenty of time to colonize the set, and the patient ends up receiving contaminated formula. Waiting for visible soiling misses the point. Bacterial contamination is invisible. By the time the tubing looks dirty, the patient has already been exposed. 24 hours scheduled every time. Here's a D439 OA exam tip for you. On tubing replacement intervals, 24 hours is the standard number to remember. Quick recall hook. 1 day, 1 tube. Question 16. An off-duty nurse stops at a highway accident, begins first aid for an unconscious driver, and leaves only once emergency medical services take over. The nurse later worries about legal liability. Which legal protection most directly applies to the nurse's actions in this situation? A. Patient Self-Determination Act. B. Health Insurance Portability Act. C. State Nurse Practice Act. D. Good Samaritan Law.
What do you think is the answer?
Correct answer. D. Good Samaritan Law. Option D is correct, because the Good Samaritan Law protects a person who renders emergency aid in good faith against most legal liability, which matches the nurse's roadside actions in this specific scenario. Option A is incorrect, because the Patient Self-Determination Act governs advance directives and informed consent inside healthcare facilities, not emergency roadside assistance provided by a bystander nurse during a crash response. Option B is incorrect, because the Health Insurance Portability Act covers privacy of protected health information and does not grant legal protection for providing physical emergency care at an accident scene. Option C is incorrect, because the State Nurse Practice Act defines nursing scope of practice and licensure, but is not the specific statute that shields emergency aid rendered in good faith outside normal work. Stopping at a highway accident raises a legal question every nurse asks: what if I get sued? The Good Samaritan Law exists for exactly that reason. It shields a person who renders emergency aid in good faith from most civil liability. The nurse in this scenario acted in good faith, provided first aid, stayed until emergency medical services took over, and then left. That is the textbook Good Samaritan situation. The Patient Self-Determination Act governs advance directives and informed consent inside facilities. It has nothing to do with roadside rescue. The Health Insurance Portability and Accountability Act, HIPAA, protects privacy of health information. It does not cover legal protection for giving emergency care. The State Nurse Practice Act defines scope of practice and licensure, but does not grant liability protection for off-duty emergency aid. Good Samaritan is the one that fits. Here's a D439 OA exam tip for you. When the STEM describes a nurse giving emergency help outside of work, the answer is always Good Samaritan. Quick recall hook. Off-duty rescue. Good Samaritan covers you. Question 17. A nurse admits a patient who has no family present, no advance directive, and is no longer able to make decisions due to declining consciousness. The care team must decide how to proceed under the Patient Self-Determination Act. What is the most appropriate course of action? A. Provide full life-saving measures as default. B. Withhold all treatment until family arrives. C. Ask another patient to decide for the men. D. Discharge the patient to home immediately.
Do you know the answer?
Correct answer. A. Provide full life-saving measures as default. Option A is correct, because the study guide directs that a patient without an advance directive who cannot construct one receives full life-saving measures by default, matching Patient Self-Determination Act principles for care. Option B is incorrect, because withholding all care while waiting for family abandons the patient during a medical emergency, and is never the guideline response under the Patient Self-Determination Act framework. Option C is incorrect, because another patient has no legal standing to consent or refuse treatment and cannot serve as a surrogate decision-maker, which fundamentally violates healthcare decision-making law and ethics. Option D is incorrect, because discharging a declining, incapacitated patient without a plan creates serious safety and legal problems and does not align with any appropriate advance directive care pathway. When a patient has no voice, no family, and no directive, the default is to preserve life. The Patient Self-Determination Act respects a patient's right to choose, but only when that choice has been made. If the patient never wrote an advance directive and cannot construct one now, the care team does not guess. They provide full life-saving measures until the situation becomes clearer. Withholding all treatment while waiting for family abandons the patient during an emergency and breaks the care obligation. Asking another patient to decide is absurd. Another patient has zero legal standing to make medical decisions for someone else. Discharging a declining, incapacitated patient without a plan creates immediate safety and legal problems and matches no advance directive framework. Default to life when the directive is missing. Here's a D439 OA exam tip for you. When the STEM describes a patient with no advance directive and declining capacity, pick the full life-saving measures option. Quick recall hook. No directive. Keep the patient alive. Question 18. A nurse applies physical restraints to a combative medical patient without a current order and without documented justification, simply to keep the patient quiet during a busy shift. The patient suffers emotional distress afterward. Which type of tort most accurately describes the nurse's actions here? A. Negligence, due to poor judgment. B. Malpractice from technical error. C. False imprisonment against the patient. D. Abandonment of a patient's care.
What do you think is the answer?
Correct answer. C. False imprisonment against the patient. Option C is correct, because the study guide defines false imprisonment as using physical restraints, seclusion, or chemical restraint to confine a patient against their will without proper justification and documentation in place. Option A is incorrect, because negligence describes a failure to provide adequate care, while this scenario involves an active, intentional confinement of the patient, rather than a simple omission or passive oversight. Option B is incorrect, because malpractice refers to illegal, improper, or negligent professional acts, while unauthorized restraint for convenience fits more precisely under the intentional tort category of false imprisonment. Option D is incorrect, because abandonment involves deserting a patient whose care has been assumed, which does not match a scenario where the nurse is physically present and actively restraining the same patient. False imprisonment sounds dramatic, but in nursing it is precise. The study guide defines it as physical restraints, seclusion, or chemical restraint used to confine a patient against their will, without proper justification and documentation. This nurse applied restraints to a combative patient for convenience, without a current order, without justification, simply to keep things quiet during a busy shift. That is the exact fact pattern false imprisonment covers. Negligence is a failure to meet the standard of care, usually passive omission. This scenario is active confinement, not passive oversight. Malpractice covers illegal, improper, or negligent professional acts, but restraint for convenience fits more precisely under the intentional tort of false imprisonment. Abandonment means deserting a patient whose care was assumed. The nurse here is physically present and actively restraining, so abandonment does not fit. Unauthorized restraint equals false imprisonment. Here's a D439 OA exam tip for you. When the stem shows restraint without an order or justification, the answer is false imprisonment. Quick recall hook. No order, no restraint, or it's false imprisonment. Question 19. A nurse becomes frustrated with a non-compliant patient and loudly tells the patient that the next refusal will result in being tied to the bed. The patient reports feeling threatened afterward. Which specific intentional tort best describes the nurse's behavior in this interaction? A. Invasion of privacy concerns. B. Assault through verbal threat. C. Battery through physical contact. D. Libel in written form.
What do you think is the answer?
Correct answer. B. Assault through verbal threat. Option B is correct, because the study guide defines assault as any threat made toward a client, typically verbal, which matches the nurse's spoken threat of restraining the patient against the patient's stated will. Option A is incorrect, because invasion of privacy relates to violating HIPAA and protected health information, not a verbal threat of restraint, which the study guide categorizes separately under the assault definition. Option C is incorrect, because battery is defined as a physical act of harm, and the scenario involves only a spoken threat without any actual physical contact or forceful touching of the patient by the nurse. Option D is incorrect, because libel refers to making false, damaging written comments about a patient, while this scenario involves a spoken threat rather than a written defamatory statement about the patient at all. Assault in nursing does not require touching. The study guide draws a clean line between assault and battery. Assault is the threat, typically verbal. Battery is the actual physical contact. When the nurse loudly tells the patient that the next refusal will result in being tied to the bed, and the patient feels threatened, that is assault. No hand was laid on the patient. No restraint was applied. The threat alone meets the definition. Invasion of privacy involves HIPAA violations and sharing protected health information without authorization. A verbal threat to restrain is not a privacy breach. Battery requires actual physical contact or forceful touching, which did not happen in this scenario. Libel is written defamation, making false damaging statements in writing. A spoken threat is not libel. Verbal threat equals assault. Here's a D439 OA exam tip for you. When the stem describes a verbal threat with no physical contact, the answer is assault. Quick recall hook. Words threaten, it's assault. Question 20. A 17-year-old legally emancipated minor is admitted to the hospital for treatment. The minor's estranged biological parents call the unit, requesting detailed updates on the minor's current condition. Under HIPAA principles described in the study guide, how should the nurse respond to this request? A. Share full medical details freely. B. Leave voicemail updates for family. C. Request a court order first. D. Release information only to the minor.
What do you think is the answer?
Correct answer. D. Release information only to the minor. Option D is correct, because the study guide teaches that emancipated minors are legally treated as adults under HIPAA, and the nurse may share protected health information only with the minor in this case alone. Option A is incorrect, because sharing full medical details with the estranged parents ignores the emancipated minor's adult legal status under HIPAA and would constitute a direct privacy violation and invasion of privacy tort, DI. Option B is incorrect, because leaving voicemail updates for family members still releases protected information to unauthorized listeners and violates the same HIPAA principles that protect an emancipated minor's private records. Option C is incorrect, because a court order is not required simply to refuse unauthorized disclosures, and the study guide does not describe this step as the standard response for emancipated minor privacy requests directly. Emancipated minors carry adult rights under HIPAA. The study guide is direct. A legally emancipated minor is treated as an adult for healthcare privacy purposes. That means the 17-year-old in this scenario controls their own protected health information, and the biological parents, estranged or not, have no automatic access. The nurse releases information only to the minor. Sharing full medical details with the estranged parents ignores the minor's adult legal status and creates a direct HIPAA violation, which would rise to an invasion of privacy tort. Leaving voicemail updates for family still releases protected information to unauthorized listeners and violates the same privacy rules. Requesting a court order first is not required simply to refuse unauthorized disclosure. The nurse can, and should, decline the request right there. Emancipated means emancipated. The parents have no standing. Here's a D439 OA exam tip for you. When the STEM mentions emancipated minor, treat the minor as an adult under HIPAA. Quick recall hook. Emancipated equals adult rights. Question 21. A nurse is caring for a patient on supplemental oxygen by nasal cannula and notices that the patient's oxygen saturation improves whenever the patient shifts position. The cannula prongs keep slipping out of the nares. Which nursing action best addresses this recurring problem? A. Place cannula securely in nose. B. Switch to a non-rebreather mask. C. Reduce the oxygen flow rate. D. Remove the cannula during movement.
Can you guess the answer?
Correct answer. A. Place cannula securely in nose. Option A is correct, because the study guide teaches that when oxygen readings improve with patient movement, the cannula is loose, and the nurse should reposition it securely inside the nose firmly. Option B is incorrect, because switching to a non-rebreather mask is a major escalation in oxygen delivery that ignores the simple mechanical issue of a cannula that keeps slipping out during patient movement. Option C is incorrect, because reducing the oxygen flow rate would lower saturation even further for a patient whose readings already depend on positioning and secure cannula placement in the nares themselves. Option D is incorrect, because removing the cannula during movement interrupts supplemental oxygen exactly when the patient needs it most and does not address the underlying mechanical placement problem behind the issue. Picture a familiar bedside moment. A patient on a nasal cannula shifts position, and suddenly, the oxygen numbers improve. That change tells the nurse something important. The cannula was loose before. Oxygen readings that rise and fall with patient movement point directly to a cannula that keeps slipping out of the nares. The fix is mechanical, not medical. Place the prongs securely in the nose. Switching to a non-rebreather mask escalates oxygen delivery for a problem that has nothing to do with the patient needing more oxygen. It treats a symptom instead of the cause. Reducing the flow rate drops oxygen even further for a patient whose readings already depend on correct placement. Removing the cannula during movement cuts off supplemental oxygen at the worst possible time and leaves the root issue untouched. Secure placement solves the actual problem. Here's a D439 OA exam tip for you. When oxygen saturation swings with position, the answer is always reposition the cannula. Quick recall hook. Loose cannula, secure placement. Question 22. A nurse notices that a patient wearing a nasal cannula for several days now has reddened skin over both cheekbones where the tubing rests against the face. The patient reports mild soreness at those spots. Which nursing action best protects skin integrity in this situation? A. Remove the nasal cannula immediately. B. Apply antibiotic ointment to the cheeks. C. Place padding around the cannula tubing. D. Switch the tubing to the opposite ear.
Can you guess the answer?
Correct answer. C. Place padding around the cannula tubing. Option C is correct, because the study guide directs nurses to place padding around nasal cannula tubing when reddened areas appear on cheekbones, which relieves pressure and protects the skin from further breakdown. Option A is incorrect, because removing the cannula stops needed supplemental oxygen, addresses skin concerns, at the expense of respiratory support, and is not the study guide's recommended response for this particular problem. Option B is incorrect, because applying antibiotic ointment treats an infection that is not present and does nothing to relieve the ongoing mechanical pressure that originally caused the skin redness at those points. Option D is incorrect, because swapping the tubing to the opposite ear shifts the same pressure to a new site, does not reduce the underlying force, and still leaves facial skin vulnerable to breakdown. Days on a nasal cannula create a predictable problem. The tubing rests on the cheekbones and presses the skin against bone. Over time, that pressure turns to redness, then soreness, then breakdown if nothing changes. The study guide's fix is padding. Place soft material around the tubing where it touches the cheekbones, and the pressure spreads out. The skin gets a chance to recover while oxygen keeps flowing. Removing the cannula altogether cuts off supplemental oxygen the patient still needs. That is protecting skin at the expense of lungs, the wrong trade. Applying antibiotic ointment treats an infection that is not there. The redness is pressure, not infection. Switching the tubing to the opposite ear shifts the same force to a new spot and creates new damage instead of preventing it. Padding fixes the cause without sacrificing the therapy. Here's a WGU D439 OA exam tip for you. When the stem shows redness from cannula tubing, pick padding. Quick recall hook. Pressure marks mean padding, not removal. Question 23. A nurse reviews a patient's vital signs and notices that the oxygen saturation reading is unexpectedly low, while the patient appears comfortable, shows normal skin color, and is breathing easily. Before calling the provider, which action should the nurse take first to verify the finding? A. Start a non-rebreather mask immediately. B. Verify placement of the pulse oximeter. C. Increase oxygen flow to maximum setting. D. Turn off the bedside monitor alarm.
Do you know the answer?
Correct answer. B. Verify placement of the pulse oximeter. Option B is correct, because the study guide teaches that when oxygen levels appear low, the nurse should first verify pulse oximeter placement, since poor probe contact often creates misleading low readings on the device. Option A is incorrect, because starting a non-rebreather mask based on an unconfirmed reading skips the basic verification step and may result in excessive oxygen therapy for a patient who does not truly need it. Option C is incorrect, because pushing oxygen flow to maximum before confirming the accuracy of the probe reading treats a number rather than the patient, whose actual clinical status appears calm and stable. Option D is incorrect because turning off the alarm hides the data without clarifying whether the reading is real, which is unsafe practice and violates the study guide's basic alarm handling and patient safety guidance. A low oxygen reading on a calm, comfortable patient is a signal to verify before reacting. The study guide says, check the probe first. Pulse oximeters are sensitive. Cold fingers, poor probe contact, nail polish, or a loose sensor can all produce a false low reading. The patient in this scenario has normal skin color, easy breathing, and no distress. That clinical picture does not match the number. When the patient looks fine and the number says crisis, the number is usually wrong. Starting a non-rebreather mask based on an unconfirmed reading overtreats a patient who may not need any escalation at all. Cranking oxygen to maximum chases a number instead of assessing the patient. Turning off the alarm hides the data and ignores a possible real change. Verify probe placement first, then act on real findings. Here's a WGU D439 OA exam tip for you. When the patient looks stable but the saturation number is low, always check the probe first. Quick recall hook: stable patient, suspect the probe. Question 24. A nurse assessing a patient in respiratory distress observes that the neck muscles, sternocleidomastoid, and external intercostal muscles are visibly pulling during each breath. The patient states that every breath feels like hard work. Which assessment finding best matches this observation? A. Normal relaxed diaphragmatic breathing. B. Guided imagery breathing technique. C. Full volume clear breath sounds. D. Use of accessory muscles during breathing.
Do you know the answer?
Correct answer. D. Use of accessory muscles during breathing. Option D is correct, because the study guide defines accessory muscles as additional muscles outside the diaphragm that flex during labored breathing, including neck muscles, sternocleidomastoid, and external intercostals, matching this clinical presentation. Option A is incorrect, because normal relaxed diaphragmatic breathing uses the diaphragm quietly and does not visibly engage neck and chest wall muscles during inhalation in a comfortable, stable, resting patient. Option B is incorrect, because guided imagery is a relaxation technique involving positive mental images, not an observable physical breathing pattern produced by struggling respiratory muscles during active patient distress. Option C is incorrect, because full volume clear breath sounds refer to auscultation findings, not to visible muscle use, and they do not describe the extra muscle recruitment seen here during each labored breath. When breathing gets hard, the body recruits help. The diaphragm cannot handle the work alone, so the patient starts using accessory muscles. The study guide names them neck muscles, sternocleidomastoid, and external intercostals. You can see these muscles flex and pull during each breath. The patient also feels it, saying every breath feels like hard work. That combination, visible muscle recruitment plus subjective report of effort, is the definition of accessory muscle use. Normal diaphragmatic breathing is quiet and invisible. You do not see neck or chest wall muscles moving in a comfortable, relaxed patient. Guided imagery is a mental relaxation technique, not a physical breathing pattern. It describes nothing about how the body is actually working. Full volume clear breath sounds come from a stethoscope, not from visual assessment, and do not describe muscle activity. Accessory muscle use is the finding here. Here's a WGU D439 OA exam tip for you. When the stem lists neck muscles, sternocleidomastoid, or intercostals pulling during breathing, pick accessory muscle use. Quick recall hook: extra muscles mean extra work. Question 25. A nurse is about to perform nasopharyngeal suctioning on a patient with copious secretions and a declining oxygen saturation. During the procedure, the nurse needs to monitor for worsening respiratory distress without relying only on equipment readings. Which direct assessment should the nurse prioritize throughout the suction pass? A. Observe skin and mucous membrane status. B. Focus on the ventilator screen output. C. Listen to heart sounds continuously. D. Time the procedure with a stopwatch.
Do you know the answer?
Correct answer. A. Observe skin and mucous membrane status. Option A is correct, because the study guide teaches that during nasopharyngeal suction, the nurse must observe the patient's skin and mucous membranes, which provide real-time clues to worsening respiratory distress or hypoxia. Option B is incorrect, because focusing only on a ventilator screen narrows the assessment to a device reading and misses the direct skin and mucous membrane clues the study guide highlights for airway safety. Option C is incorrect because continuous heart sound auscultation is impractical during active suctioning, does not replace the skin and mucous membrane check, and is not the guidelines designated priority observation during suction. Option D is incorrect because timing the procedure with a stopwatch tracks duration but ignores the patient's physiologic response, which is the clinically meaningful indicator of tolerance during each suction pass. Suctioning can make a patient worse before it makes them better. During the pass, the nurse needs direct clues about how the patient is handling it. The study guide points to skin and mucous membrane status as the priority observation. Color changes in skin and lips give real-time feedback. Pale, gray, or dusky color signals hypoxia before any machine catches up. Pink and warm means the patient is tolerating the pass. Focusing only on the ventilator screen narrows attention to one data point and misses the whole picture. The machine lags behind the patient. Continuous heart sound auscultation during active suctioning is impractical and distracts from the procedure itself. It is not the guidelines priority observation. Timing the procedure with a stopwatch tracks duration but says nothing about whether the patient is coping. Direct observation of skin and mucous membranes beats every other option. Here's a UGD 439 OA exam tip for you. During suctioning, always pick the answer that involves direct patient observation over device readings. Quick recall hook. Watch the patient, not just the screen. Question 26. A nurse is assigning tasks to an unlicensed assistive personnel during a busy shift. The nurse must decide which responsibilities the UAP can safely accept and which must stay with licensed staff. Based on standard delegation rules, which task is most appropriate to assign to the UAP? A. Initial admission assessment of a new patient. B. Primary medication, teaching for a diabetic. C. Bathing and feeding a stable patient. D. Evaluation of post-operative wound drainage.
Can you guess the answer?
Correct answer. C. Bathing and feeding a stable patient. Option C is correct because the study guide's UEAT rule lists bathing, dressing, feeding, and transferring as safe UAP tasks, while reserving assessment, evaluation, and teaching for the licensed nurse only. Option A is incorrect because initial admission assessment clearly falls under the A in UEAT, and the study guide specifically prohibits a UAP from performing first, initial, priority, or post-operative assessments on any assigned patient. Option B is incorrect because primary medication teaching matches the T in UAAT, which the study guide reserves for the licensed nurse because initial, first, and primary patient education cannot be delegated to a UAP. Option D is incorrect because evaluation of post-operative wound drainage aligns with the EA in UAAT, and the study guide forbids a UAP from trending, interpreting, or evaluating clinical data on any assigned patient case. Delegation has rules, and the study guide uses a clean acronym to remember them. UEAT, the letters stand for unstable patients, evaluation, assessment, and teaching. Those 4 categories cannot go to a UAP. Everything outside those categories is potentially fair game. Bathing and feeding a stable patient falls safely inside the UAP's scope. Those are personal care tasks that do not require clinical judgment. Initial admission assessment falls under the UEAT and stays with the licensed nurse. Primary medication teaching for a diabetic falls under the T and also stays with the nurse. Evaluation of post-operative wound drainage falls under the E and requires licensed judgment. Bathing and feeding a stable patient is the only option that matches UAP scope. Here's a UGD 439 OA exam tip for you. When the question asks what a UAP can do, look for personal care on a stable patient and rule out anything involving U, E, A, or T. Quick recall hook. UEAT stays with the nurse. The rest stays with care tasks. Question 27. A charge nurse overhears a UAP agreeing to complete the initial admission assessment for a newly arrived patient because the primary nurse is overwhelmed with another admission. The charge nurse must intervene quickly. Which action best protects the patient and follows delegation rules? A. Reassign the assessment to a licensed nurse. B. Let the UAP finish the assessment. C. Delay the assessment until later. D. Document the assessment after the UAP.
Can you guess the answer?
Correct answer. A. Reassign the assessment to a licensed nurse. Option A is correct because initial assessments fall under the A in UEAT, and the study guide requires a licensed nurse to perform the first, priority, or post-operative assessment of any new patient. Option B is incorrect because letting the UAP finish the assessment violates the delegation rule that bans UAPs from conducting initial assessments, and allowing the task to continue would place the patient at direct safety risk. Option C is incorrect because delaying the assessment until later creates a care gap for a newly admitted patient, fails to establish a baseline quickly, and does not solve the original workload issue requiring licensed staff intervention. Option D is incorrect because documenting an assessment after a UAP performed, it would create inaccurate records, violate nursing scope of practice rules, and expose the nurse to potential malpractice and tort liability under the guidelines. A charge nurse overhearing a UAP about to do an initial assessment has one job: stop the assignment and reassign it to a licensed nurse. The initial admission assessment falls squarely under the A in UEAT. The study guide is absolute on this point. First assessments, priority assessments, and post-operative assessments all require the licensed nurse's clinical judgment. A UAP cannot perform them, no matter how busy the unit gets. Letting the UAP finish the assessment breaks the delegation rule and puts the patient at risk. A missed finding in the first assessment sets the tone for the entire admission. Delaying the assessment until later leaves the new patient without a baseline and does not solve the workload issue. Documenting the assessment after the UAP performed it creates a false record and invites malpractice liability. Reassigning to a licensed nurse is the only safe move. Here's a D439 OA exam tip for you. When a UAP is about to do an initial assessment, pick the answer that redirects the task to a licensed nurse. Quick recall hook. Initial assessment, licensed hands only. Question 28. Tee off. A newly admitted patient with diabetes needs primary teaching on insulin injection technique before discharge home. The nurse considers asking a UAP with personal diabetes experience to deliver the initial education session. Which response best reflects safe practice under standard delegation guidelines? A. Let the UAP teach the technique. B. Ask the UAP to demonstrate insulin. C. Split teaching tasks with the UAP. D. Keep primary teaching with the licensed nurse.
What do you think is the answer?
Correct answer. D. Keep primary teaching with the licensed nurse. Option D is correct because initial, first, and primary patient education fall under the T in UEAT, and the study guide reserves this teaching category strictly for the licensed nurse only. That so this teaching category strictly for the licensed nurse only. Option A is incorrect because letting the UAP teach the technique violates the rule that primary patient teaching cannot be delegated, regardless of the UAP's personal experience, because the license and accountability remain with the nurse. Option B is incorrect because asking the UAP to demonstrate insulin injection still moves initial teaching to an unlicensed person, and the study guide bans this transfer even when the UAP appears to have the relevant procedural knowledge base. Option C is incorrect because splitting teaching tasks with the UAP still assigns part of primary instruction to an unlicensed worker, which the study guide prohibits because first-time teaching remains the licensed nurse's protected responsibility entirely. Primary teaching is licensed work, full stop. Even if a UAP has personal diabetes experience, first-time insulin injection education falls under the T in UEAT, The study guide reserves this category for the licensed nurse alone. The reason is accountability. A primary teaching session forms the foundation of a patient's self-care skills at home, and errors at this stage translate into dangerous medication mistakes later. The license carries the legal responsibility, and the license stays with the nurse. Letting the UAP teach the technique violates the delegation rule outright. Personal experience does not substitute for professional education and accountability. Asking the UAP to demonstrate insulin still moves initial teaching to an unlicensed person. That is the same violation under a different label. Splitting teaching tasks with the UAP assigns part of the primary instruction to unlicensed staff, which the study guide bans. The teaching stays with the nurse. Here's a Beijingguo D439 OA exam tip for you. When the STEM involves first-time patient education, pick the licensed nurse. Quick recall hook. First teach, licensed reach. Question 29. A nurse plans the afternoon workload and needs to assign several personal care tasks on a medical unit. The nurse wants to keep clinical decision-making with licensed staff while using the UAP efficiently. Which cluster of tasks fits safely within the UAP's scope of practice? A. Evaluating trends in vital signs. B. Bathing, dressing, feeding and transferring patients. C. Interpreting lab values and reporting changes. D. Teaching patients about new medications.
What do you think is the answer?
Correct answer. B. Bathing, dressing, feeding, and transferring patients. Option B is correct because the study guide lists bathing, dressing, feeding, and transferring as core tasks that fall within the UAP's scope and do not require a licensed nurse's clinical judgment. Option A is incorrect because evaluating trends in vital signs falls under the E in UEAT, meaning a UAP cannot trend or interpret clinical data, and this responsibility stays with the licensed nurse under every delegation framework. Option C is incorrect because interpreting lab values and reporting changes is a form of evaluation, which the study guide bars a UAP from performing, because trending data and drawing clinical meaning require the nurse's licensed judgment entirely. Option D is incorrect because teaching patients about new medications represents initial education, which the study guide's UEAT rule reserves for the licensed nurse, since first-time instruction on medications carries significant clinical risk. The study guide puts 4 personal care tasks clearly inside the UAP's scope: bathing, dressing, feeding, and transferring. These are concrete, hands-on jobs that do not require clinical interpretation. A UAP can perform them safely on stable patients without crossing into licensed territory. Evaluating trends in vital signs falls under the E in UAAT. Trending means comparing numbers over time and drawing clinical meaning from the pattern, which is licensed judgment. Interpreting lab values and reporting changes is also evaluation. The UAP can report a raw number but cannot interpret what it means. Teaching patients about new medications is initial education, which falls under the TA. Primary instruction stays with the nurse. The 4-task bundle of bathing, dressing, feeding, and transferring is the safe UAP cluster. Here's a D439 OA exam tip for you. When the question lists task clusters, pick the one filled with personal care, not clinical interpretation. Quick recall hook. Hands-on care for UAP. Head-on care for nurse. Question 30. A UAP reports to the nurse that a post-operative patient's blood pressure readings have been trending down all afternoon and asks whether the pattern is worrisome. The nurse recognizes a delegation boundary issue. What is the most appropriate nursing response in this moment? A. Interpret the trend yourself. B. Ask UAP to watch for drops. C. Let UAP document the interpretation. D. Tell UAP to call the provider directly.
Do you know the answer?
Correct answer. A. Interpret the trend yourself. Option A is correct, because the study guide places trending and interpreting clinical data under the E in UEAT. keeping evaluation tasks with the licensed nurse who carries the accountability. Option B is incorrect because asking the UAP to watch for further drops still positions an unlicensed worker to monitor and interpret changes, which the study guide bars because data interpretation sits outside a UAP's delegated scope entirely. Option C is incorrect because letting the UAP document the interpretation pushes evaluation responsibility onto unlicensed staff, creating an inaccurate clinical record and violating both the delegation rules and basic documentation integrity standards. Option D is incorrect because telling the UAP to call the provider directly skips the nurse's required assessment and interpretation steps, puts clinical communication in unlicensed hands, and removes the nurse from the accountability chain entirely. When a UAP reports trending vital signs and asks if the pattern is worrisome, the nurse has to take the interpretation back. Trending and drawing meaning from clinical data falls under the E in UEAT. The UAP can gather the numbers. The nurse interprets them. Accountability for evaluation stays with the license. Asking the UAP to watch for further drops still places monitoring and interpretation with unlicensed staff, which the study guide prohibits. The UAP has already handed the data up the chain. The nurse takes it from there. Wow, and the letting the UAP document the interpretation creates an inaccurate clinical record and exposes the nurse to documentation integrity violations. Telling the UAP to call the provider directly skips the nurse's required assessment and interpretation steps and removes licensed judgment from the communication loop. The nurse interprets. The nurse acts. Here's a D439 OA exam tip for you. When a UAP asks if a trend is worrisome, take the interpretation yourself. Quick recall hook. UAP gathers, nurse interprets. Question 31. A nurse enters a room and finds a patient struggling angrily to pull a clean shirt over a recent shoulder surgery, muttering about being unable to dress alone anymore. The patient throws the shirt on the bed and sighs heavily. Which response best reflects therapeutic communication? A. Why are you throwing the shirt? B. Calm down and try again later. C. Do not get upset over this. D. This must be frustrating for you.
Can you guess the answer?
Correct answer. D. This must be frustrating for you. Option D is correct, because the study guide points to this must be frustrating for you as the therapeutic response that validates emotion and invites the patient to share feelings openly and honestly. Option A is incorrect, because asking why questions sounds judgmental and makes the patient feel criticized, which the study guide specifically warns against because it shuts down communication instead of inviting honest emotional expression. Option B is incorrect because telling a frustrated patient to calm down dismisses the feeling, minimizes the experience, and blocks the therapeutic relationship the study guide highlights as the core of caring nursing communication. Option C is incorrect because telling the patient not to be upset invalidates a real emotional reaction, blames the patient for feeling, and directly opens the door to a therapeutic breakdown rather than building a supportive nursing exchange. Therapeutic communication rewards validation over judgment. A patient struggling with a shirt after shoulder surgery is frustrated, embarrassed, and angry at the loss of independence. The nurse who says this must be frustrating for you names the feeling out loud and opens the door for the patient to share more. That sentence is the study guide's model therapeutic response. Asking why are you throwing the shirt sounds judgmental and critical. Why questions put the patient on the defensive and shut communication down. The study guide specifically warns against them. Telling the patient to calm down and try again later dismisses the emotion and minimizes the experience. Calm down is the classic therapeutic mistake. Telling the patient not to get upset blames the patient for feeling and blocks the relationship entirely. Validation first, always. Here's a D439 OA exam tip for you. On therapeutic communication questions, pick the answer that names the patient's feeling without judgment. Quick recall hook. Name the feeling, open the door. Question 32. A nurse wants to explore a patient's recent mood changes without sounding harsh or triggering defensiveness. The patient has mentioned feeling tired of everything and quickly changed the subject. Which type of question should the nurse use to open a deeper, supportive therapeutic conversation with this patient? A rapid-fire yes or no question. B. A direct why question. C. An open-ended question about feelings. D. A leading, closed-ended opinion question.
Do you know the answer?
Correct answer. C. An open-ended question about feelings. Option C is correct, because the study guide directs nurses to use open-ended questions during therapeutic conversations, since the open format invites fuller emotional disclosure and supports real dialogue with the patient. Option A is incorrect, because rapid-fire, yes or no, questions limit the patient's response to single words, shut down emotional exploration, and conflict with the therapeutic communication principles the study guide associates with genuine listening. Option B is incorrect, because a direct why question sounds judgmental and can push the patient toward defensiveness, and the study guide explicitly teaches nurses to avoid the word why in sensitive therapeutic care exchanges. Option D is incorrect, because a leading, closed-ended opinion question pulls the patient toward the nurse's assumption rather than exploring real feelings, which violates the study guide's preference for neutral, open prompts in therapeutic exchanges. Open-ended questions carry the weight in therapeutic conversations. When a patient mentions feeling tired of everything and changes the subject fast, the nurse senses something deeper underneath. The right move is an open-ended question about feelings, which invites the patient to speak fully without steering the answer. The study guide treats open-ended questions as the default tool for real emotional dialogue. Rapid-fire yes or no questions lock the patient into single-word replies. They cut off exploration and treat feelings like data points. That is not therapeutic communication. A direct why question sounds judgmental and pushes the patient toward defensiveness. The study guide warns nurses away from why in sensitive exchanges. A leading, closed-ended opinion question pulls the patient toward the nurse's assumption instead of the patient's own experience. That violates the neutrality the study guide calls for. Open format, open patient. Here's a D439 OA exam tip for you. When the STEM involves exploring emotions, pick the open-ended question option. Quick recall hook: open questions, open hearts. Question 33. A nurse is preparing to explain a new medication and treatment plan to an older adult patient who has limited health literacy and appears confused by unfamiliar medical terms. Which communication approach best fits the study guide's recommendations for teaching older adults clearly and respectfully? A. Use plain, everyday language when explaining. B. Use advanced medical jargon consistently. C. Speak very quickly to save time. D. Skip the explanation entirely for simplicity.
What do you think is the answer?
Correct answer. A. Use plain everyday language when explaining. Option A is correct, because the study guide directs nurses to use everyday language when explaining issues to older adults, which supports understanding, respects the patient, and reduces the risk of misunderstanding instructions. Option B is incorrect, because using advanced medical jargon consistently creates a communication barrier for patients with limited health literacy, directly opposes the study guide's plain language guidance, and raises the risk of medication errors at home. Option C is incorrect, because speaking very quickly to save time overwhelms an older adult who is already confused, reduces retention of essential safety information, and undermines the respectful pace the study guide emphasizes for patient teaching. Option D is incorrect, because skipping the explanation entirely abandons the teaching role of the licensed nurse, ignores the patient's right to informed consent, and violates the study guide's emphasis on clear communication before any new treatment. Plain everyday language wins with older adults who have limited health literacy. The study guide sets the standard clearly. Use familiar words, skip the jargon, and speak at a pace the patient can follow, saying pain reliever instead of analgesic, high blood pressure instead of hypertension, swelling instead of edema. That simple shift protects understanding, respects the patient, and cuts down on medication errors at home. Using advanced medical jargon consistently creates a wall. The patient nods politely, misses the point, and goes home unprepared. That is the opposite of safe teaching. Speaking very quickly to save time overwhelms a confused older adult and destroys retention. Rushed teaching is failed teaching. Skipping the explanation entirely abandons the teaching duty, strips away informed consent, and violates a basic expectation the study guide makes of every licensed nurse. Plain language is the professional standard. Here's a YGU D439 OA exam tip for you. When teaching older adults, pick the plain language answer every time. Quick recall hook. Simple words, strong understanding. Question 34. A nurse must complete an intake assessment that includes questions about a patient's sexual activity history. The patient appears reserved and has become quiet whenever personal topics come up. How should the nurse structure this sensitive conversation to match therapeutic communication principles? A. Open with the most explicit questions first. B. Begin with less sensitive questions first. C. Ask questions only through a translator. D. Skip the sexual history completely.
Do you know the answer?
Correct answer. B. Begin with less sensitive questions first. Option B is correct, because the study guide directs nurses to begin with questions less sensitive in nature when asking about sexual activity, which builds trust gradually before moving into more personal material. Option A is incorrect, because opening with the most explicit questions first overwhelms a reserved patient, triggers shutdown, and violates the study guide's clear instruction to start with less sensitive prompts when exploring sexual history topics. Option C is incorrect, because requiring a translator for a patient who speaks English adds an unnecessary barrier, disrupts the trusting therapeutic relationship, and does not match the study guide's standard approach for sensitive history intake questions. Option D is incorrect, because skipping the sexual history completely leaves a gap in the intake assessment, misses important risk and safety data, and abandons the therapeutic conversation that the study guide expects the nurse to conduct. Sensitive conversations need a ramp, not a dive. When the intake includes sexual history and the patient already appears reserved, the study guide says begin with less sensitive questions first. Start with broad health topics, move into lifestyle, and only later move toward the more personal territory. Trust builds gradually. The patient gets comfortable answering smaller questions before the bigger ones come up. Opening with the most explicit questions first shocks a reserved patient into shutdown. The therapeutic relationship closes before it started. That violates the study guide's ramp-up principle. Requiring a translator for a patient who speaks English adds an unnecessary barrier and disrupts the trust the nurse is trying to build. It is not the standard approach for sensitive intake. Skipping the sexual history completely leaves a gap in the assessment, misses important risk and safety data, and abandons the therapeutic duty. Ramp up slowly. Here's a DGU D439 OA exam tip for you. On sensitive history questions, pick the answer that starts with less sensitive material first. Quick recall hook, ease in, then dig deeper. Question 35. Tutors. A patient tells the nurse about worry over an upcoming surgery and then falls silent. The nurse wants to respond in a way that acknowledges the concern, shows respect, and encourages the patient to share more about the underlying feelings. Which reply works best therapeutically? A. There is no reason to worry. B. Everyone feels nervous before surgery honestly. C. Why exactly are you worried about surgery? D. You are worried. Tell me more.
What do you think is the answer?
Correct answer. D. You are worried. Tell me more. Option D is correct, because the study guide directs nurses to state facts and then invite the patient to share feelings through an open-ended prompt, which validates the concern and encourages deeper emotional disclosure. Option A is incorrect, because telling the patient there is no reason to worry dismisses the emotion, blocks any further disclosure, and violates the study guide's guidance to validate feelings before offering reassurance in therapeutic conversations. Option B is incorrect, because generalizing that everyone feels nervous before surgery minimizes the patient's unique experience, pushes the emotion aside, and conflicts with the study guide's focus on validating individual feelings during therapeutic communication. Option C is incorrect, because asking why exactly are you worried uses the word why, which the study guide tells nurses to avoid because it sounds judgmental and shuts down the therapeutic conversation quite quickly. When a patient shares worry and then falls silent, the nurse's reply has weight. The study guide's model response is, "You are worried, tell me more." That answer does two things at once. It names the feeling, which validates the emotion. Then it invites the patient to share more through an open-ended prompt. Both moves are therapeutic. Telling the patient there is no reason to worry dismisses the feeling and blocks further disclosure. The patient learns that the nurse is not a safe place to share. That violates the study guide's validation principle. Generalizing that everyone feels nervous before surgery minimizes the patient's unique experience and pushes the emotion aside. It treats the worry like a statistic instead of a real feeling. Asking why exactly are you worried uses the forbidden why, which sounds judgmental and shuts down the conversation. State the feeling, then invite more. Here's a D439 OA exam tip for you. The best therapeutic response names the emotion and then opens space for disclosure. Quick recall hook. Name it, then invite it. Question 36. A nurse is completing a full pain assessment on a patient reporting new abdominal discomfort. The nurse wants a structured approach that captures onset, provoking factors, quality, radiation, severity, and timing. Which assessment framework best matches the study guide's recommended structured approach to pain? AOPQRST, Structured Framework. B. ADPIE, Nursing Process Framework. C. SBAR, Communication Framework. D. UEAT, Delegation Framework.
Can you guess the answer?
Correct answer. AOPQRST, Structured Framework. Option A is correct, because the study guide uses OPQRST for pain assessment, capturing onset, provocation, quality, radiation, severity, and timing as the 6 essential elements for structured evaluation of pain. Option B is incorrect, because ADPIE represents the 5 steps of the nursing process: assessment, diagnosis, planning, implementation, and evaluation, which applies to overall care planning rather than to a targeted structured pain assessment framework. Option C is incorrect, because SBAR is a handoff communication tool standing for situation, background, assessment, and recommendation, used to structure updates to providers rather than to guide a detailed structured pain assessment at the bedside. Option D is incorrect, because UEAT is the delegation rule listing tasks that cannot be delegated to a UAP. Unstable patients, evaluation, assessment, and teaching, which governs task assignment rather than structured pain assessment on the unit. Pain assessment gets a dedicated acronym in the study guide, OPQRST. Each letter covers a specific piece of the pain picture. Onset, when did it start? Provocation, what makes it better or worse? Quality, what does it feel like? Radiation, where does it travel? Severity, how intense is it? Timing, when does it happen? 6 elements together build a full structured pain assessment. ADPIE is the nursing process, a different framework entirely. Assessment, diagnosis, planning, implementation, evaluation. It covers overall care planning, not pain specifics. SBAR is a handoff tool. Situation, background, assessment, recommendation. It structures communication to providers, not pain assessment at the bedside. UAAT is the delegation rule, covering tasks that cannot go to a UAP. It governs assignments, not pain. OPQRST is the pain framework. Here's a D439 OA exam tip for you. When the STEM asks about a structured pain assessment, pick OPQRST. Quick recall hook. Pain gets OPQRST, all 6 letters. Question 37. A nurse observes a post-operative patient grimacing while shifting in bed and holding the surgical site. Yet, the patient insists on being in no pain when asked directly. The nurse senses a mismatch between behavior and report. What is the most appropriate next action for the nurse? A. Document only the patient's denial. B. Administer pain medication immediately. C. Ask what is causing the grimacing. D. Reassure the patient and move on.
Can you guess the answer?
Correct answer. C. Ask what is causing the grimacing. Option C is correct because the study guide directs nurses to explore the behavioral mismatch when a patient grimaces but denies pain, since the observed grimacing may reveal hidden discomfort or a different underlying cause. Option A is incorrect because documenting only the denial ignores clear nonverbal distress, leaves a gap in the pain assessment, and violates the study guide's expectation to investigate when behavior and patient report do not align clinically. Option B is incorrect because administering pain medication immediately without further assessment skips the verification step the study guide requires, risks giving unnecessary medication, and may mask another underlying problem behind the observed grimacing. Option D is incorrect because reassuring the patient and moving on dismisses a clear nonverbal pain cue, leaves the discrepancy unexplored, and conflicts with the study guide's guidance to investigate and clarify before accepting a pain denial. Behavior and report do not always match, and the study guide expects the nurse to investigate when they diverge. A patient grimacing while shifting and guarding the surgical site shows clear nonverbal pain cues. When that same patient insists on no pain, the gap is worth exploring. The nurse asks, "What is causing the grimacing?" That question is curious, non-judgmental, and opens space for the patient to explain. The real cause might be hidden pain, fear of medication, or something else entirely. Documenting only the patient's denial ignores the nonverbal distress and leaves a gap in the assessment. That is a documentation integrity problem waiting to happen. Administering pain medication immediately skips the verification step and risks giving an unneeded dose. Medication without assessment is backwards. Reassuring the patient and moving on dismisses the nonverbal cue and conflicts with the study guide's directive to investigate mismatches. Ask first, then act. Here's a D439 OA exam tip for you. When the patient's body says pain but the words say no pain, pick the answer that investigates. Quick recall hook. Mismatch means ask. Question 38. A nurse is caring for a patient with chronic post-surgical pain whose analgesic has a short therapeutic window and is easily missed during a busy shift. The patient's ideal outcome is to stay pain-free throughout the day. Which nursing approach best supports this goal? A. Wait until the patient requests pain medication. B. Double the dose once a day. C. Delay doses to reduce total medication. D. Give analgesics around the clock.
What do you think is the answer?
Correct answer. D. Give analgesics around the clock. Option D is correct, because the study guide directs nurses to follow the routine administration of prescribed analgesics around the clock, since short therapeutic windows require timely dosing to keep the patient pain-free. Option A is incorrect because waiting for the patient to request pain medication allows pain to build between doses, falls behind the short therapeutic window, and contradicts the study guide's guidance on staying ahead of chronic post-surgical pain. Option B is incorrect because doubling the dose once a day exceeds the prescribed order, risks serious adverse effects, and does not address the real issue of maintaining steady analgesic coverage throughout each full shift and day. Option C is incorrect, because delaying doses to reduce total medication leaves the patient unprotected, allows breakthrough pain to establish itself, and directly conflicts with the study guide's instruction not to be late on giving analgesics. Staying ahead of pain beats chasing it. When the analgesic has a short therapeutic window, waiting for the patient to ask for a dose guarantees breakthrough pain. The study guide directs nurses to give analgesics around the clock, matching the schedule in the order, not the patient's request. Around-the-clock dosing keeps blood levels steady. The patient stays comfortable without the peaks and valleys that come from reactive dosing. That is the goal for chronic post-surgical pain. Waiting until the patient requests pain medication falls behind the short therapeutic window. By the time the patient asks, pain has already taken hold, and catching up takes longer than preventing it. Doubling the dose once a day exceeds the prescribed order and risks adverse effects. It does not solve the steady coverage problem. Delaying doses to reduce total medication leaves the patient unprotected and lets breakthrough pain establish itself. That is the opposite of what the study guide teaches. Scheduled dosing wins. Here's a D439 OA exam tip for you. When the patient has chronic pain with a short therapeutic window, pick around-the-clock dosing. Quick recall hook. Stay ahead of the pain, clock the doses. Question 39. A nurse medicates a patient for moderate abdominal pain and returns later to check in. The patient reports that the pain has not improved since the dose was given, yet the patient also appears more withdrawn and quiet. What is the most appropriate nursing action in this situation? A. Reevaluate the pain carefully. B. Wait and reassess next shift. C. Double the previous dose. D. Document improvement anyway.
Do you know the answer?
Correct answer. A. Reevaluate the pain carefully. Option A is correct, because the study guide directs nurses to reevaluate pain when it fails to improve after treatment, since new symptoms, insufficient dosing, or a different underlying problem may require prompt follow-up. Option B is incorrect, because waiting until next shift delays needed reassessment, allows unrelieved pain to continue, and it ignores the study guide's direction to act promptly when the current pain response is clearly inadequate for the patient. Option C is incorrect because doubling the previous dose without a new order exceeds prescribed limits, risks adverse reactions, and skips the required reassessment step, violating safe medication practice and the study guide's pain management approach. Option D is incorrect because documenting improvement anyway creates false records, hides an unresolved problem, and exposes the nurse to tort liability for incorrect documentation, which violates legal and professional standards outlined in the study guide. Unrelieved pain after treatment is a reassessment trigger. When a patient reports no improvement after a dose and also looks more withdrawn and quiet, something has shifted. The study guide directs the nurse to reevaluate the pain carefully. The reassessment catches new symptoms, insufficient dosing, or a different underlying problem that needs attention. Withdrawal and quietness can signal worsening pain, fear, depression, or a complication brewing under the surface. None of that comes out unless the nurse asks. Waiting until next shift to reassess delays care and lets unrelieved pain continue. That violates the study guide's direction to act when the current response is clearly inadequate. Doubling the previous dose without a new order exceeds prescribed limits, risks adverse reactions, and skips the reassessment step entirely. That is unsafe practice. Documenting improvement anyway creates false records, hides a real problem, and exposes the nurse to tort liability for incorrect documentation. Reassess carefully. Here's a D439 OA exam tip for you. When pain does not improve after a dose, pick the option that reevaluates. Quick recall hook. No relief means reassess. Question 40. A nurse is beginning a new pain assessment for a patient recovering on a medical unit. The nurse wants an objective, quick way to measure the patient's current pain intensity so future reassessments can be compared reliably over the course of the shift. Which tool fits best? A. A lengthy open-ended interview. B. A blood pressure measurement only. C. A pain number scale. D. A casual non-verbal observation only.
Do you know the answer?
Correct answer. C. A pain number scale. Option C is correct, because the study guide directs nurses to ask about pain using a number scale, which gives a fast, objective baseline and supports consistent comparisons across repeated reassessments during the shift. Option A is incorrect, because a lengthy open-ended interview has a place in broader pain exploration, but does not deliver the fast numeric baseline needed for repeated comparison during the shift, which is the specific purpose here. Option B is incorrect, because a blood pressure measurement alone gives an indirect clue about stress, but does not measure pain intensity itself, and the study guide does not list it as the primary tool for structured pain assessment. Option D is incorrect because a casual nonverbal observation alone misses the patient's own report of intensity, provides no reliable number for trending, and leaves the nurse without the consistent baseline the study guide expects in structured pain care. A pain number scale gives the nurse a fast, objective baseline. The study guide directs nurses to ask about pain using a number scale, usually 0 to 10. 0 means no pain. 10 means the worst pain imaginable. The patient picks the number. That single number becomes the reference point for every reassessment during the shift. If pain was a 7 at the start and drops to a 3 after medication, the nurse knows the treatment worked. Trending is simple when the data is numeric. A lengthy open-ended interview has a role in broader pain exploration, but does not deliver the fast numeric baseline needed for repeated comparison. It takes too long for routine reassessment. A blood pressure measurement alone gives an indirect stress clue, but does not measure pain intensity. The study guide does not list it as the primary tool. A casual nonverbal observation alone misses the patient's own report of intensity and gives no reliable number for trending. Numbers make comparison possible. Here's a D439 OA exam tip for you. When the STEM asks for a quick, objective comparable pain measure, pick the number scale. Quick recall hook. 0 to 10, pain goes in. Question 41. A nurse is preparing to insert an indwelling urinary catheter in a post-operative patient. The nurse has gathered all needed equipment and reviewed the step order from the study guide. Which approach best reflects safe, study guide consistent technique during the actual insertion of this catheter? A. Use clean technique with bare hands. B. Open sterile package toward the body. C. Reach across the sterile field freely. D. Maintain sterile technique throughout the procedure.
Do you know the answer?
Correct answer. D. Maintain sterile technique throughout the procedure. Option D is correct, because the study guide classifies Foley catheter insertion as a sterile procedure, requiring sterile gloves, sterile field, and careful technique throughout to prevent urinary tract infection and patient harm. Option A is incorrect, because using clean technique with bare hands turns Foley insertion into a medical asepsis procedure, which the study guide does not allow because catheterization demands surgical asepsis to prevent urinary tract infection. Option B is incorrect, because opening a sterile package toward the body can contaminate the outermost flap, compromise the sterile field, and violate the study guide's sterile technique rule to open the pack of instruments away from the body. Option C is incorrect, because reaching across the sterile field freely breaks the study guide's rule against reaching over the field past sterile gloves, introduces contaminants from above, and ruins the surgical asepsis needed for safe insertion. Foley catheter insertion is a sterile procedure, not a clean one. The study guide is clear on this distinction. Surgical asepsis applies from the moment the kit opens until the catheter is secured. Sterile gloves, sterile field, and careful technique throughout. The reason is simple. The urinary tract is normally closed to the outside world, and inserting a tube bypasses every natural defense. Contamination during insertion is a direct path to urinary tract infection. Using clean technique with bare hands turns the procedure into medical asepsis, which the study guide does not allow for catheterization. Opening a sterile package toward the body contaminates the outermost flap when the nurse reaches over it. The rule is open the pack away from the body. Reaching across the sterile field freely breaks another core sterile rule. Anything passing over the field introduces contaminants from above. Maintain sterile technique from start to finish. Here's a D439 OA exam tip for you. When the stem involves Foley catheter insertion, pick the answer that preserves sterile technique throughout. Quick recall hook. Foley equals fully sterile. Question 42. A nurse reviews the patient's chart before Foley catheter insertion and notes a documented allergy to shellfish. The insertion kit contains an iodine-based antiseptic solution. The nurse must decide how to adjust the procedure before opening the sterile field. Which action best matches safe practice? A. Use the iodine anyway cautiously. B. Skip iodine and use non-iodine solution. C. Rinse the iodine off immediately after. D. Dilute the iodine with sterile water.
What do you think is the answer?
Correct answer. B. Skip iodine and use non-iodine solution. Option B is correct, because the study guide directs nurses to avoid iodine when the patient has a shellfish or iodine allergy, substituting a non-iodine antiseptic to prevent a serious allergic reaction during the procedure. Option A is incorrect because using the iodine anyway cautiously still exposes the allergic patient to a known trigger, risks anaphylaxis, and ignores the study guide's clear instruction to skip iodine when allergy to shellfish is documented. Option C is incorrect because rinsing the iodine off after application still allows contact with a known allergen, can trigger a reaction before rinsing, and does not follow the study guide's preventive rule of avoiding iodine entirely. Option D is incorrect because diluting iodine with sterile water lowers the concentration, but does not eliminate the allergen, still risks a significant reaction, and clearly violates the study guide's straightforward no iodine rule for documented allergy. A shellfish allergy is an iodine warning. The study guide teaches that patients allergic to shellfish react to iodine compounds, and the standard povidone iodine antiseptic in most catheter kits becomes a serious risk. The fix is simple. Skip the iodine, grab a non-iodine antiseptic. No exposure, no reaction. Using the iodine anyway cautiously still exposes an allergic patient to a known trigger. Cautious use does not prevent anaphylaxis, which can happen within minutes. The study guide gives no permission for this workaround. Rinsing the iodine off after application does not help. The allergic contact has already happened, and the reaction is already in motion by the time the rinse starts. Diluting iodine with sterile water lowers the concentration but does not eliminate the allergen. Even small amounts can trigger a serious response. The rule is absolute. No iodine, period. Here's a big D439 OA exam tip for you. When the stem mentions a shellfish allergy before a Foley, pick the non-iodine antiseptic. Quick recall hook. Shellfish allergy. Skip the iodine. Question 43. A nurse checks the drainage bag after 2 hours and notes that the total urine output has been very low, well below expected hourly volumes for this patient. The patient's vital signs are stable but trending. What is the most appropriate nursing interpretation and action? A. Suspect kidney distress and notify provider. B. Continue monitoring without notifying provider. C. Assume normal variation and do nothing. D. Flush the catheter with sterile water.
Do you know the answer?
Correct answer. A. Suspect kidney distress and notify provider. Option A is correct because the study guide teaches that very low urine output signals kidney distress, prompts the nurse to notify the provider, and often leads to drawing bun and creatinine levels next. Option B is incorrect, because continuing to monitor without notifying the provider delays a needed evaluation of kidney function, misses the warning sign the study guide highlights, and risks further deterioration before anyone can intervene clinically. Option C is incorrect, because assuming normal variation and doing nothing ignores the study guide's clear threshold for kidney concern, fails to act on a real clinical warning, and leaves the patient without the safety net they need. Option D is incorrect, because flushing the catheter with sterile water without an order assumes mechanical obstruction without assessment, bypasses the real concern of kidney distress, and does not follow the study guide's urine output response steps. Very low urine output is a kidney warning the nurse cannot ignore. The study guide treats output below expected hourly volumes as a signal of kidney distress. The kidneys are losing the ability to filter properly, and that change deserves provider attention right away. The next step usually involves drawing bun and creatinine levels to check kidney function directly. Catching this early matters because kidney injury can progress fast if the cause is not identified and addressed. Continuing to monitor without notifying the provider delays a needed evaluation. The warning sign has already shown up. Waiting longer lets the problem worsen without clinical oversight. Assuming normal variation and doing nothing ignores the study guide's threshold for concern. Very low output is not a variation, it is a finding. Flushing the catheter with sterile water without an order assumes a mechanical obstruction without assessment and bypasses the real concern about kidney function. Call the provider. Here's a D439 OA exam tip for you. When urine output drops well below expected, pick the answer that notifies the provider for kidney distress. Quick recall hook. Low output, loud alarm. Question 44. A nurse has removed an indwelling urinary catheter from a post-operative patient and plans to confirm that the bladder can empty without assistance. The patient feels well, but has not reported any urge to void yet. Which nursing action best follows the study guide after catheter removal? A. Reinsert the catheter right away. B. Restrict fluids for the next hours. C. Ask when the patient voided after removal. D. Skip any bladder follow-up assessment.
Do you know the answer?
Correct answer. C. Ask when the patient voided after removal. Option C is correct, because the study guide directs nurses to ask the patient when they voided after catheter removal, which assesses the bladder's ability to empty without the catheter in place. Option A is incorrect, because reinserting the catheter right away adds unnecessary invasive care, raises infection risk, and skips the normal assessment step the study guide expects before returning to an indwelling catheter after a removal. Option B is incorrect, because restricting fluids after catheter removal reduces urine production, hides whether the bladder is emptying normally, and conflicts with the study guide's focus on assessing voiding patterns following any catheter removal. Option D is incorrect because skipping any bladder follow-up assessment leaves the nurse blind to possible urinary retention, ignores the study guide's specific post-removal assessment instruction, and places the patient at risk for silent bladder problems. After a catheter comes out, the nurse needs to know if the bladder still works on its own. The study guide directs nurses to ask the patient when they voided after removal. That question is short, direct, and checks the most important outcome. Did the bladder empty without help? If yes, the system is working. If no, the patient may be heading toward urinary retention and needs a bladder scan or another intervention. Reinserting the catheter right away adds invasive care. The study guide does not jump back to catheterization without first checking voiding. Restricting fluids after catheter removal reduces urine production, hides whether the bladder is emptying, and blocks the very assessment the nurse is trying to do. Skipping any bladder follow-up assessment leaves the nurse blind to possible urinary retention, which can progress silently and damage the bladder wall. Ask about voiding. Here's a WGIU D439 OA exam tip for you. After catheter removal, pick the answer that assesses voiding. Quick recall hook. Catheter out. voiding check. Question 45. A nurse is teaching a new graduate how to perform routine daily care on a patient's indwelling urinary catheter. The new graduate asks how the perineal area and the catheter itself should be cleaned to lower infection risk and keep the line in good working condition. Which response fits best? A. Use alcohol wipes on the catheter. B. Leave the catheter untouched during care. C. Scrub the catheter with abrasive cloth. D. Wash with soap and water daily.
Can you guess the answer?
Correct answer. D. Wash with soap and water daily. Option D is correct, because the study guide directs nurses to keep the catheter clean by washing both the catheter and the surrounding area with soap and water as part of routine daily catheter care. Option A is incorrect because using alcohol wipes on the catheter can dry and damage the tubing material, does not match the gentle soap and water cleaning described in the study guide, and may irritate sensitive perineal tissue. Option B is incorrect because leaving the catheter untouched during daily care allows buildup of secretions along the tubing and meatus, raises infection risk, and skips the specific cleaning step the study guide requires each shift. Option C is incorrect because scrubbing the catheter with an abrasive cloth can tear the tubing surface, damage the urethral meatus, and conflicts with the gentle wash and rinse approach the study guide uses for routine catheter care. Routine catheter care uses soap and water. That is the study guide's clear direction for daily cleaning. Wash the catheter itself and the surrounding perineal area with gentle soap and water each day. The approach is simple because the goal is simple. Keep the site clean, limit bacterial buildup, and protect the tubing without damaging anything. Using alcohol wipes on the catheter dries and weakens the tubing material over time. Alcohol also irritates sensitive perineal tissue. That is not the gentle cleaning the study guide describes. Leaving the catheter untouched during daily care lets secretions build up along the tubing and around the meatus. The longer that buildup sits, the higher the infection risk climbs. Scrubbing the catheter with an abrasive cloth tears the tubing surface, can damage the urethral meatus, and contradicts the wash and rinse approach the study guide requires. Soap, water, daily. Here's what you'd give D439 OA exam tip for you. On catheter hygiene questions, pick the soap and water answer. Quick recall hook. Soap and water, simple and safe. Question 46. A nurse has an order to apply physical restraints to a confused patient who keeps attempting to climb out of bed. The nurse selects appropriate wrist restraints and prepares to secure them. Which attachment point best matches safe restraint practice according to the study guide? A. Secure restraints to the side bed rails. B. Secure restraints to the bed frame itself. C. Secure restraints to the firm headboard. D. Secure restraints to the overbed table.
Can you guess the answer?
Correct answer. B. Secure restraints to the bed frame itself. Option B is correct because the study guide directs nurses to tie restraints to the bed frame itself using slip knots, which keeps the restraint stable when the bed rails or head of bed move. Option A is incorrect because tying restraints to the bed rails violates the study guide's explicit rule against this practice, since movable rails can shift suddenly and tighten the restraint or injure the patient during position changes. Option C is incorrect because tying restraints to the headboard also violates the study guide's rule, since the head of the bed can rise and fall during care, creating unsafe tension and potential injury on the patient's limbs. Option D is incorrect because tying restraints to the overbed table provides no stable anchor, since the table rolls and lifts freely, which makes it unsafe for patient confinement and falls completely outside study guide recommendations. Restraints go to the bed frame, not the rails or the headboard. The study guide is specific on this point. Tie restraints to the bed frame itself using slip knots. The frame stays stable when the bed rails move or the head of the bed rises and falls. That stability protects the patient from injury during routine care. Securing restraints to the side bed rails violates the study guide's explicit rule. Rails move. When the rails shift, the restraint tightens or loosens without warning, and the patient can get hurt. Securing restraints to the headboard breaks the same rule. The head of the bed rises and falls during care, creating unsafe tension on the restraint and the patient's limbs. Securing restraints to the overbed table is worse. The table rolls and lifts freely. It provides no stable anchor at all. The frame is the only safe attachment point. Here's a D439 OA exam tip for you. When the STEM asks where to tie restraints, pick the bed frame. Quick recall: hook, frame stays, rails move. Question 47. A nurse has just applied soft wrist restraints to a combative patient with a valid order. The nurse plans ongoing monitoring to catch circulation problems before they cause harm. Which assessment should the nurse perform first after applying the restraints, and then at regular short intervals afterward? A. Temperature check every hour. B. Blood pressure every half hour. C. Capillary refill every 15 minutes. D. Daily weight each morning.
Can you guess the answer?
Correct answer: C. Capillary refill every 15 minutes. Option C is correct because the study guide teaches that capillary refill is the first assessment after applying restraints and is then repeated every 15 minutes to catch any circulation compromise before tissue damage develops. Option A is incorrect because checking temperature every hour does not reliably detect circulation problems at the restraint site, misses the specific capillary refill check the study guide requires, and fails to monitor for the primary risk of tightness. Option B is incorrect because blood pressure every half hour offers a global measure, but does not target distal circulation at the wrist restraint, misses tight straps, and does not match the study guide's specific every 15-minute capillary refill schedule. Option D is incorrect because daily weight each morning is not a restraint-specific circulation check, offers no information about distal perfusion at the wrists, and completely misses the study guide's short interval monitoring requirement for applied restraints. Capillary refill every 15 minutes is the restraint monitoring standard. The study guide puts this check at the front of the post-restraint assessment routine. Capillary refill tells the nurse whether blood is still reaching the hand past the restraint. Press the nail bed, release, count the seconds until color returns. If refill slows, the restraint is too tight and tissue damage is starting. The 15-minute interval catches problems before they become permanent. Temperature check every hour does not reliably detect circulation problems at the restraint site. A warm arm is not the same as an arm with good capillary refill. The hourly temperature misses the specific check the study guide requires. Blood pressure every half hour gives a global measure of circulation but does not target distal perfusion at the wrist. Tight straps can cut off hand circulation without changing the overall blood pressure. Daily weight each morning is not a restraint-specific check at all. It tells the nurse nothing about circulation at the restraint site. Capillary refill every 15 minutes. Here's a D439 OA exam tip for you. When the STEM asks about monitoring after restraint application, pick capillary refill every 15 minutes. Quick recall: hook, 15 and refill every time. Question 48. A nurse returns to work the morning after a shift, during which a confused patient was placed in wrist restraints with a valid order. The patient remains restrained this morning, and the nurse reviews the chart. What is the most important action the nurse should take about the restraint order now? A. Obtain a new restraint order. B. Continue with the original order indefinitely. C. Remove all restraints without assessment. D. Document the existing order one more time.
Do you know the answer?
Correct answer: A. Obtain a new restraint order. Option A is correct because the study guide teaches that restraint orders remain valid for only 24 hours, and the nurse must obtain a new order before continuing to use the restraints on the patient. Option B is incorrect because continuing with the original order indefinitely violates the 24-hour limit from the study guide, exposes the nurse to false imprisonment tort concerns, and places the patient under unauthorized restraint after expiration. Option C is incorrect because removing all restraints without assessment abandons the clinical reasoning that originally supported the order, may place a confused patient at immediate fall or injury risk, and is not the study guide's first step here. Option D is incorrect because documenting the existing order one more time does not extend the order's validity beyond 24 hours, leaves the patient in unauthorized restraint, and ignores the need for a provider's renewed clinical judgment. Restraint orders expire in 24 hours. The study guide sets this limit hard. After 24 hours, the original order no longer justifies the restraint. The nurse must obtain a new order from the provider before continuing to restrain the patient. The renewed order forces fresh clinical judgment. Is the restraint still needed? Has the patient's condition changed? The provider answers those questions at each new order, which protects the patient from unnecessary extended confinement. Continuing with the original order indefinitely violates the 24-hour limit, exposes the nurse to false imprisonment tort concerns, and places the patient under unauthorized restraint. The calendar does not care that the first order felt reasonable. The order has expired. Removing all restraints without assessment abandons the clinical reasoning behind the original order. A confused patient still at fall or injury risk cannot be suddenly unrestrained without evaluating whether the reason for restraint still exists. Documenting the existing order one more time does not extend its validity. Paperwork cannot overrule a time-based expiration. Get a new order. Here's a D439 OA exam tip for you. On restraint renewal questions, pick obtain a new order. Quick recall hook. 24 hours, renew or release. Question 49. A nurse is setting up a safe environment for an older adult admitted to a medical unit with a history of recent falls at home. The family asks, what simple environmental changes can reduce the risk of another fall during the overnight period on the unit? Which change fits best? A. Keep the room completely dark overnight. B. Remove all grab bars from the bathroom. C. Store personal items far from reach. D. Keep the room well lit for safety.
Do you know the answer?
Correct answer. D. Keep the room well lit for safety. Option D is correct because the study guide teaches that a well-lit room helps prevent falls in elderly patients by supporting safe ambulation, better visual cues, and clear pathway recognition during movement in the room. Option A is incorrect because keeping the room completely dark overnight removes the lighting cues older adults rely on for safe movement, increases trip risk, and directly conflicts with the study guide's well-lit room recommendation for seniors. Option B is incorrect because removing all grab bars from the bathroom strips away an important fall prevention aid, raises the risk of slipping during toileting, and contradicts basic environmental safety principles for older adult fall prevention. Option C is incorrect because storing personal items far from reach forces the patient to stretch, bend, or climb, which directly increases fall risk and contradicts the study guide's guidance to keep needed items already within reach. A well-lit room prevents falls in older adults. The study guide is direct on this environmental control. Good lighting supports safe ambulation, makes pathways clear, and gives older eyes the visual cues they need to move without tripping. Older adults have slower visual adaptation and reduced depth perception, so dim or dark spaces become hazards. Keeping the room completely dark overnight removes the lighting cues older adults rely on for safe movement. Getting up to the bathroom in the dark, even with a night light missing, raises trip risk significantly. The study guide recommends the opposite. Removing all grab bars from the bathroom strips away a key fall prevention aid. Grab bars give patients something to hold during toileting, which is a common fall scenario. Taking them away makes the bathroom less safe. Storing personal items far from reach forces the patient to stretch, bend, or climb, each of which raises fall risk. Keep needed items within easy reach. Light, grab bars, and items within reach are the three environmental fall prevention basics. Here's a D439 OA exam tip for you. On fall prevention environment questions, pick the well-lit room answer. Quick recall hook. Light the room, lower the falls. Question 50. A nurse is asked to manage a restless, confused patient who keeps pulling at a necessary intravenous line. The nurse wants to protect the line while honoring the study guide's approach to restraint use as a last option, rather than a first choice. Which intervention should the nurse try first? A. Apply 4-point physical restraints immediately. B. Administer a strong sedative right away. C. Try the least invasive intervention first. D. Restrict the patient to bed alone.
Can you guess the answer?
Correct answer. C. Try the least invasive intervention first. Option C is correct, because the study guide directs nurses to start with the least invasive option and move up only if needed, reserving restraints for cases where safer alternatives have already been tried. Option A is incorrect, because applying 4-point physical restraints immediately skips the progressive, least to most invasive approach the study guide requires, risks unnecessary restraint use, and may expose the nurse to false imprisonment concerns for unjustified confinement. Option B is incorrect, because administering a strong sedative right away represents a chemical restraint applied without first trying less invasive alternatives, which the study guide treats as inappropriate as a first-line response to confused behavior. Option D is incorrect, because restricting the patient to bed alone without other measures does not address the pulling behavior, offers no engagement or redirection, and skips the least invasive interventions the study guide lists as the proper starting point. Restraints are a last resort, not a first move. The study guide teaches a stepped approach. Start with the least invasive intervention and escalate only if the earlier step fails. For a restless patient pulling at an IV line, that means trying redirection, distraction, a sitter, disguising the line under clothing, or calming techniques before any restraint comes into play. Restraints carry real risks. Skin breakdown, circulation problems, emotional distress, and legal exposure if applied without proper justification. They belong at the top of the escalation ladder, not the bottom. Applying 4-point physical restraints immediately skips the progressive approach entirely. It jumps to the most restrictive option without trying anything else first. The study guide does not allow that shortcut. Administering a strong sedative right away is chemical restraint applied without first trying less invasive alternatives. Chemical restraints fall under the same restraint rules as physical ones. Restricting the patient to bed alone does nothing to address the pulling behavior, provides no engagement, and is not a least invasive intervention at all. Try the least invasive option first. Here's a D439 OA exam tip for you. When the STEM involves protecting a line from a restless patient, pick the least invasive intervention first. Quick recall hook. Least first, restraints last.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.